Today we're tackling one of the absolute cornerstones of medicine, a doctor's duty of care. It sounds so simple, doesn't it? A doctor's job is to care for their patient. But as we're about to find out, that very simple idea is actually at the center of some of medicine's toughest, most complex dilemmas. So let's just start with a really basic question. When you walk into a doctor's office, what do you assume is their single most important job? Well, the answer seems pretty obvious. It's to care for you, the patient, right? Your health, your well-being, that's priority number one. Except it's just not that straightforward. In the real world, that core duty gets stretched and pulled in all kinds of directions, by pressure from the hospital system, by the needs of medical research, and even by some really tricky questions about who or what even counts as a patient. And this creates some serious ethical tightropes for the people we trust with our lives. So let's dive into the first big conflict, the individual patient versus the demands of the entire healthcare system. Okay, check this out. This slide lays out the fundamental tension perfectly. On one hand, you've got the classic Declaration of Geneva, which says the patient is the first consideration, full stop. But then, on the other hand, you have groups like the Medical Council of New Zealand telling doctors they have to do this balancing act, weighing their duty to you against their duty to the whole community. And listen, this is not just some academic theory. Research from public hospitals in Australia found that when it comes to critical end-of-life decisions, doctors straight up admitted that they do think about resource limits. Things like the cost or the availability of an ICU bed, yeah, that can actually become part of the calculation. And this gets to what really worries doctors themselves. They're afraid that a decision to stop treatment because of a lack of resources, money or beds, could get mixed up with or even disguised as a purely medical decision that the treatment isn't working anyway. Is the treatment truly futile, or can the hospital just not afford it? That's a huge, huge dilemma. Now, what happens when a doctor's job isn't just to heal you, but also to discover new cures? The line gets even fuzzier when your doctor is also a researcher and you're not just a patient, but a participant in a clinical trial. This brings us to a really important idea called the therapeutic misconception. It's this super common thing where a person in a study believes the treatment they're getting is designed specifically for them, to make them better. But in reality, they're part of a scientific protocol designed to create data for future patients. And this just blows up the whole idea of informed consent. For consent to be real, it's got to be about more than just signing a paper. The most important thing isn't knowing every little scientific detail. What's absolutely critical is understanding why you're doing it and having a genuine appreciation of the situation. Basically, do you get the big picture of what you're signing up for? This leads to a really simple but powerful way to check for understanding. A researcher can just ask the person, what would you be giving up by joining this trial? If they can't answer that, if they don't realize they might be passing on a standard, proven treatment, for example, then they probably haven't really understood what they're agreeing to. All right, for our final section, we're going to push the boundaries of who or even what we consider a patient. This is where the whole idea of duty of care gets really interesting. So think about this scenario. A child who was conceived through an egg donation develops a genetic condition. Does the doctor now have a duty to track down and contact the anonymous donor from years ago to help with the diagnosis? I mean, that's a person they've never met, who isn't their patient in any traditional sense. And you might think that's a super rare niche problem, but it's not. As genomics and genetic testing become totally normal parts of healthcare, these tangled family trees and biological connections mean that pretty much all health professionals are going to have to deal with these kinds of extended duties. But what if we take it a step further? Does a doctor's duty of care somehow extend to a person who isn't even alive anymore? It's actually a pretty common practice in med schools to try and instill that sense of respect and duty right from day one. Students are often taught to think of the cadavers they work on in anatomy lab as their first patient. And while that's a really powerful way to teach, it also highlights a problem. The whole point of an anatomy lab is learning, right? But the point of a clinic is healing. The ethical goals are completely different. So when we use the same phrase, duty of care, for both, it can actually create a lot of confusion about what that duty really means. So, after looking at the system and at research and even at the deceased, where does all this leave us? Well, it pretty much forces us to step back and rethink what we actually mean by duty of care. If there's one thing to take away from all this, it's that the duty of care isn't some single rigid rule that applies the same way everywhere. It's really a flexible idea that has to adapt to the situation. So, what that means is we have to be really thoughtful. We have to think hard about how much priority we give the duty of care. We have to think about how it gets weighed against other important duties, like spending public money wisely. And we've got to be super careful about the confusion that happens when we try to apply it to places like research or education, where the main goal isn't just treating one person. And that leaves us with the big, lingering question. In a complicated world with limited resources, competing priorities, and responsibilities that just keep expanding when one doctor has many, many duties, who really comes first?